All right, now we're gonna move on to our next article. We're talking about osteoarthritis in the knee and hip and exercise. And OA, or osteoarthritis, is a leading cause of disability affecting millions of people worldwide, right? But therapeutic exercise or exercise is widely recommended for managing OA in the knee and hip. However, not all patients respond to exercise equally, and the factors that influence its effectiveness are still under investigation. And so what we're looking at here is we're gonna try to figure out how can we figure out the people in the patient population that respond best to exercise. Who are those people, or is it all the same for everybody? So we're going to dive in here to this study. So first and foremost, prevalence of OA. OA is a significant cause of disability. Like I mentioned, the global prevalence has been rising due to an aging population and increasing rates of obesity. As I've talked about previously many times, is that, hey, we are finding that osteoarthritis has a very strong link to metabolic disease and obesity. And, since about 1990, we're up about 9% of the prevalence of osteoarthritis. Now about 3,000 people out of every 100,000 have arthritis. And the current treatment guidelines, the international guidelines, including those from the American College of Rheumatology and Osteoarthritis Research Society International, recommend therapeutic exercise as a core treatment for hip and knee OA. But should that be the case? Let's dive in. So moving here, the importance of therapeutic exercise. First of all, what is therapeutic exercise? Therapeutic exercise refers to a structured physical activity aimed at improving or maintaining a specific health condition like OA. So therapeutic exercise essentially exercises medicine. We are specifically targeting for it. It includes things like aerobic exercises, strengthening, flexibility, and balance exercises. And overall, the general benefits for exercise in OA, research has consistently shown that exercise can reduce pain and increase physical function in people with hip and knee OA. However, the effects are often small to moderate, and the benefits can actually decline over time. And only about 50% of people who do this get a clinically significant response. So that was actually surprising to me. Only 50% of people get a clinically significant response. A lot of times I'll tell people, hey, we want to exercise as our first line, but knowing here only about a coin flip of people are going to get that, that's kind of depressing as well. All right, now let's discuss the findings of the meta-analysis here. And this meta-analysis included 31 randomized controlled trials with just over 4,000 people. And the goal was to identify, hey, what specific individual level effects were the biggest changes that we saw on the people who responded to exercise. So the people who had hip and knee OA, what things or what people specifically led to the improvement in there. They used individual participant data, which is unique because a lot of times in big studies, they group everybody together. So they essentially say, hey, you include Tom and Martha here. Tom had an amazing benefit, but Martha had nothing. They might just cancel each other out and show no benefit, but like Tom definitely had benefit. And so we're trying to figure out what happened there with Tom that we did. Obviously, there's nobody named Tom in the paper. That would be a very big HIPAA violation. But that's the general idea of why they're using individual data, which is really cool. And overall, there were 37 different exercise modalities that were studied. The duration varied. The delivery method, meaning online, in-person, home-based, that all changed. And on average, therapeutic exercise did reduce pain and improve physical function compared to non-exercise controlled trials. However, the effect was much smaller than we thought it would be, which is actually interesting. And most people say exercise is the most important thing, and I'll say that myself, but it doesn't seem like for everybody it had a big effect. On the group, it looked like a moderate effect. However, baseline pain and physical function did seem to influence things as well, meaning people who had higher pain and worse physical function seemed to benefit more from exercise. So that's kind of like one of the big takeaways, is that people who had worse pain and worse function had the most to improve from exercise. So there was significant variability, though, between the responses we talked about. So the baseline pain severity, we're diving a little deeper here. This analysis revealed that patients with higher baseline pain scores, like I mentioned, benefit more from exercise, with the greatest improvement in those reporting a pain scale above a 40. So on a 0 to 100 pain scale, people who had a 40 above there, they seem to have the greatest improvement. And why is this? Well, I don't know, shoulder shrug emoji. Nobody really knows. They think that maybe patients with severe symptoms have a higher potential for improvement, right? So if you have a terrible life, you're super inhibited by arthritis, then you've got more to benefit, right? As someone who says, hey, yeah, I have a little pain here, that's a lot harder to do. So that's kind of like the main idea why I think this is the case. And on top of that, baseline physical function, individuals with poorer physical function at baseline, once again, showed greater improvement in both pain and physical function following that. And probably the same idea, right? If you are almost bedbound from arthritis, then you have much more to gain than someone who's very, very functional and just has a little achy knee after they exercise. So the difference is what we think that's why what's going on. And overall, this does suggest that therapeutic exercise may be most beneficial for patients with more advanced OA or those who are experiencing a significant functional impairment. That's kind of what we're thinking about. And there were no other factors that really showed significance, which was great because, we shouldn't use other factors as a reason not to prescribe exercise, right? So they looked at things like diabetes and obesity, and they didn't necessarily see that those things affected it. And so the way I take it is, hey, we should be prescribing exercise to almost everyone. And specifically, most people would think the reverse was true, right? Like, hey, like if you're really having bad OA, we shouldn't prescribe exercise. It might make it worse. Like, well, the data shows it's actually the opposite. It might make it better. And I still think you should prescribe exercise to people who have moderate or mild OA because it's just good for your overall health. And so really there's nobody we shouldn't be prescribing for, but maybe our expectations should change just a little bit. That's kind of one of the big takeaways here. And so the clinical takeaways here is that they indicate that exercise interventions may need to be tailored specifically based on the baseline pain or function levels. In patients with severe, pain or physical function, they should be prioritized for therapeutic exercise, and they're likely to experience the greatest benefit, which is awesome. And they did see a lot of short-term improvements, but the long-term improvements may be a little limited. And clinicians, we should kind of consider, incorporating long-term exercise programs and combining therapeutic exercise with other treatments as well, such as weight management and pain relief strategies to kind of improve overall outcomes. And, overall, the findings do kind of question the magnitude of expected benefit from exercise, right? And people with knee or hip OA, it's kind of adding to the growing body of evidence that kind of raises this uncertainty about exercise with osteoarthritis. And I've mentioned before, I'm kind of starting to consider OA as almost a metabolic disease. Not necessarily, if you've had a previous ACL tear and you tear your knee, you're going to have post-traumatic arthritis. Most likely that's not due to metabolic dysfunction, but there's a strong correlation. So it's kind of understand that multi-pronged approach, right? Exercise for all the things it does from a metabolic perspective, from a weight loss perspective, then you work on maybe other lifestyle things. It's kind of, a multi-pronged approach is kind of what I'm thinking. And overall here, diving into physiologic mechanisms as well. Once again, the big thing is we're not quite sure, but exercise maybe improves outcomes by enhancing muscle strength, increases joint stability, cardiovascular fitness, and collectively all that could reduce OA symptoms. If I had to guess as well, probably decreasing inflammation in your body, all those things. And although not all the patients respond equally to exercise, the variability could be due to a bunch of different things that we don't know about as well. So the study didn't find strong evidence that factors like age or BMI significantly moderate the effect. But when we're looking at this many things, people are very confusing. So it could be a lot of things. And moving on here, there were limitations. Obviously, one limitation of this was that we use this individual participant data from several of the RCTs are missing that data. So it's kind of hard to include all the data. And we had so many different exercises. It's very heterogeneous, meaning the time or the type, the duration, all these things were not quite what's going on, and it may affect generalizability in the future. And so more studies are obviously needed, but overall, once again, just kind of taking home the conclusion here is that therapeutic exercise does provide small but meaningful improvements in pain and physical function for people with knee or hip OA, especially with those with a higher baseline pain or worse function. So especially those who have the most pain or the worst function. However, long-term effectiveness is not sure, but I still think it's probably worthwhile. But tailoring exercise might be the move, meaning, hey, we're going to tailor it for specifically, we should be prioritizing people with more pain or worse baseline function, which is kind of interesting and not what I necessarily thought. And if you found this information helpful, then you might enjoy this next video that YouTube recommends as well.